Welcome, everyone, to part 3 of the core concepts in quality and safety. It's really a big chapter, lots to talk about. And I'm joined today by Lal Saw. And can you introduce yourself a little bit for our listeners?
Yes, hi. I'm back again. I'm a fourth year medical student at University of Massachusetts, and QI is something that I want to learn way more about because it's interesting and it's something that we can actually implement change in. So I'm excited to be here today.
Thank you, Lal. And the way our conversation has been going, I already learned a lot from you. So I think you already know everything there is to know. It's wonderful. One of the things that comes up in this non-interpretive skills syllabus from the ABR is that 2001 IOM report, Crossing the Quality Chasm. And that was really a sentinel report in medicine. They reported that we kill between 44 and 95,000 patients a year. And since then, there have been publications saying it's up to 250,000 patients that we kill in healthcare every year due to avoidable errors. It's really despicable. I think it was anticipated that there would be a huge outcry in the medical community when they saw this report. And there was. It did trigger a huge change, and it forced everybody to adopt quality improvement methods in medicine. But we haven't really achieved as much progress as we would like to see for a variety of reasons. The takeaway piece here is there are 6 goals for quality of care that were defined in the book. And I remember them by the acronym STEEP with 3 E's. STEEP. The acronym stands for safe, timely, effective, efficient, equitable. And then the P is for patient centered. Let's go over these 6. Safe, I think, is self explanatory, right? Can you think of some safety hazards in healthcare for patients?
Other patients, germs that are the environment itself can create a safety
Yes,
hazard.
hand washing or lack of hand washing is a big issue in hospitals. So hospital-acquired infections, and they can kill some patients that are already sick and with lowered immune defense, and they can die from that. Then the wrong medication errors are a big hazard in healthcare, where either you get the wrong medication altogether or you get a medication that you're allergic to because somehow this alert of your allergy wasn't known or it didn't trigger a response. Or you get the wrong dose of a medication because there's the trailing zero issue. There's somebody put in the wrong dose and it gets dispensed in that way. And so those are all safety hazards. Falls are very common in the hospital. That's why all patients have to wear these socks that prevent falls. But there are other measures that we're supposed to take when there's a patient at risk for fall. So there's a risk assessment tool. Getting the wrong surgery, if people get amputated the wrong leg or get surgery on the wrong spinal level for back pain, those things all can happen. Yeah, so those are all big safety hazards, and there's a lot of stuff you don't even think about that is a safety hazard. Okay, now the 3 E's: effective, efficient, and equitable. Let's start with efficient. What does that mean to you?
It goes for not wasting the patient's time and resource, the hospital's time and resource, and as a component, the provider's time and resource. I think
Yeah. That's
making the
good. So that's definitely the time waste, although there's also timeliness of care where that is part of that. But to me, efficiency is getting to the next management step for the patient as quickly as possible. So avoiding unnecessary tests, avoiding wait times, definitely having appointments available as soon as possible. That's all efficient. So you don't waste anybody's time. You don't waste resources like imaging studies that are not needed or lab tests that don't need to be done, things like that. So that's efficient. How about effective?
so what we initially say as best and correct procedures, processes, and treatments. So providing services that are based on current guidelines and the current most up-to-date knowledge that we know can actually benefit the patients, all the good stuff.
Yeah, good. So we don't want to waste time on treatments or management that doesn't really advance the patient's healthcare journey and it wastes their time. So we don't want to do tests or interventions that don't help. but we want to get to the stuff that is proven to work. So if there's any evidence that says this is what you should do to help the patient, then we should follow that. Good. So that's effective. How about equitable?
So being able to provide the same quality and type of and the quantity of care to all patients, regardless of what geographic location, what financial circumstance. So I think this is what we really focus on these days about health equity, social determinants of health, being able to balance it. So it's not about equality, it's about equity, meeting where the patient is at and being able to all bring them to the same level and quality of care.
Okay, great. So that's equitable. Health equity is such a big buzzword right now, really making care available to everyone in the same way. There's so many issues with access. So in radiology, for example, a lot of patients don't have access to mammogram screening. And that's why in some communities, they have a bus going around with the mammogram machine on the bus. And so that
Yep.
everybody can go there and come get their mammogram done. So these issues are so widely spread and we don't even know about it. Can you imagine living in like a rural area somewhere and having a stroke where you're like miles away from the next stroke center and knowing you need to get there quickly? It must be horrible. And so we have timely care we already touched upon. We don't want any wait or waste of time. And then patient-centered, what does that mean?
We touched upon this if you were listening to our other episodes, but providing not only care that is like respectful, but care that is best for how the patient perceives it. So taking into consideration their preferences, their needs, and their values. And the other component was actively making them a participant in their care. So in other words, shared decision making. So they are a stakeholder in their decision and their care.
Perfect. Yeah, that I couldn't say it any better. So that's that. That's basically the key takeaway from that publication from the IIM report in 2001. And it still holds true today. So when I think about quality improvement projects, I always make sure that they meet at least one of these goals. I wish we could get everybody to find a project that is aligned with one of these 6 elements: safe, effective, efficient, equitable, timely, and patient-centered. Good. One other thing to talk about is actually the ACGME core competencies. Because of these core competencies, we do have non-interpretive skills questions on exams like the American Board of Radiology board exams. I just want to go over that a little bit. The ACGME is the Accreditation Council for Graduate Medical Education.
Yep.
And they have milestones they put together for every specialty. So when you go into radiology, there are diagnostic radiology milestones, and they are in these different categories. And we see there's 6 different categories. So the first one is practice-based learning and improvement. Then there is patient care and procedural skills, system-based practice, medical knowledge, interpersonal and communication skills, and professionalism. So let's just touch on what each of these means so that we have an agreement on these items. Practice-based learning and improvement. What do you think that is?
I guess because it's practice based, as physicians, we interact with patients, evaluate them, see what's wrong with them. So being able to do that, but also use your learning. So the knowledge that you have and scientific knowledge specifically, and being able to apply that to like the way you actually practice medicine. So if you're reading radiology reports, I assume I'm not a resident yet, but being able to see, is this kind of method scientific, or is this efficient, effective? Is this kind of evidence based? And then being able to change how they approach the way they interpret a report, maybe, or make a report.
Yeah, the practice-based learning and improvement is basically the quality improvement component of the training, where you are able to appraise and identify current practice and look for gaps that can be improved, and then use improvement method to improve it. And it also includes evidence-based practice. So that's part of the practice-based learning and improvement. It's a little bit different from medical knowledge, which was one of the other items. So medical knowledge is purely learning medicine and learning radiology, all the imaging signs on each modality and the differentials and all of that. So that's part of the medical knowledge. How is that different from patient care and procedural skills?
I think the guidelines helped me when I was reading it. It said it's the actual care that you're providing and what kind of motivation is behind it. So being compassionate, is the care appropriate? Are you providing treatment that is actually effective? So are you helping the problem and helping the patient? So patient
Right.
care.
Yeah, that's perfect. And then we do have procedures in radiology as well.
Yeah.
So we have interventional radiology as its own procedural specialty, but a lot of the diagnostic radiologists also do procedures. So, for example, in breast imaging, we do biopsies and marking lesions, and abdominal imaging, we drain abscesses and place tubes and do biopsies. In neuroimaging, we do lumbar punctures and vertebral body procedures and things like that. Procedural skills, they're typically evaluated in a qualitative way through observation and rating. There's the old paradigm of see one, do one, teach one.
Mhm.
Have you heard that before?
Yes, I've heard that
See one,
before.
do one. It's brutal. Yeah, I don't know. The first time somebody showed me, is, okay, we're going to do a lumbar puncture. You're going to see one and then you're going to do one. I so anxious. It's, oh my God. Now we have more opportunity for simulation, which is so much better, where you can try something on a model first after you've seen it and then get let loose on the patient. But
Yes.
in many areas, we don't have that simulation yet, but it's something worthwhile thinking about. Okay, that's that. And then there is systems-based practice. That's a blurry term. Do you have any idea what that means?
I think it's important to find where you belong in a larger group or system, as says. So, as a provider, what department do I fall under? What institution do I fall under? And what area of expertise do I fall under? And with that knowledge, being able to coordinate things better, being able to play your role, but also play a role in the big system.
Yeah, yeah. There are certain portions of our practice that are important for the system. For example, in my organization, when I observe an error, there is a reporting system, and it's part of my professional duty to report the case so that the system can learn from the error and help prevent this type of error in the future. So, something like that, a systems based practice, participation in multidisciplinary conferences where patient cases are discussed and managed. That systems-based practice. Those are all processes the system has set up to provide better care. So those are good examples. And then there is interpersonal and communication skills and professionalism. But how would you say they're different?
Whatever profession you go into, for us, it's healthcare providers, being a physician, being able to fulfill the responsibilities of our job title and doing it in a ethically correct manner and being able to use those ethics internally and being able to apply it. And then the interpersonal and communication skills, I think, goes into having an effective exchange with not only your patients, but all your coworkers. I think the professionalism is definitely how you act, but also it's how you embody and what mindset you have and how you approach things. And I think the interpersonal and communication skills, how you interact and using that mindset with all the people you actually work with.
Yeah, I agree with you. It's very closely related. I think communication skills is definitely a part of professionalism, but there are certain skills specifically in the workplace that stand out. The professionalism, by the way, we have a different chapter on that for the listeners. You may want to look for that podcast. Professionalism is about the ethical principles that define a certain profession. So we have rules and laws and things that we swear by, patient autonomy and things like that, do no harm, and how we carry ourselves, how we follow the rules. So following the rule means showing up when your shift starts or doing the CME to maintain your license, not claiming CME from a meeting in Hawaii when you were at the beach all day while the meeting was happening. So those are all the items of professionalism. But for communication skills, it's a very specific skill set. And when I think about communication with patient, it could be disclosure. disclosure that something had happened, we did the wrong exam, we injected the wrong contrast, or something else that happened that you want to disclose. Other discussions we have for procedures are skills of getting informed consent, how you build rapport, and how you explain things in a patient-centered way so you don't use the technical terminology, but you speak in layman's terms. And also shared decision making, like in interventional radiology, those procedures are often an alternative to surgery. So you have to explain that to patients and guide them through that decision making process to come to a shared decision at the end. And then obviously, if you communicate with other members of the healthcare team, we're all working together to make patients' lives better. And
Yeah.
it's not helpful to make our colleagues miserable by yelling or demeaning behavior and things like that. So that all
Yeah.
goes under those categories. Okay, so that's very comprehensive. I actually looked at the milestones for diagnostic radiology and I counted every single item on that list, and it turned out that almost 50% of what is on the milestones falls under non-interpretive skills. It's really amazing. And if you think about the lecture time and the teaching that we do in a residency program is mostly focused on medical knowledge. Okay, great. This was a good discussion. And our next meeting, we're going to go into the core concepts of safety. Thank you so much, Lyle.
Thank you.